The talk is basically about local therapy for metastatic prostate cancer. Essentially, I'm going to be looking at local therapy options, talking about some of the rationale and evidence from a preclinical, then clinical side of things, and then eventually go into some future questions and conclusions. So local therapy is specifically referring to treatment of the primary prostate, and we usually do that more for people who have non-metastatic prostate cancer. That includes, of course, surgical techniques and radiation-based techniques. But actually, quite a few metastatic prostate cancer patients will ultimately end up having local therapy as well. And this is actually mainly due to palliation of complications from related to the primary disease. How common is this? One study looked at a series of metastatic patients, and about 78% of patients on that trial actually ended up having symptoms related to the prostate primary. Of course, if they start to have complications, it can vary from light to severe, and accordingly, basically, the management options are also based on that as well. So that can include medications, and don't forget that includes long-term opiate use, but it could also include radiation and surgical techniques. Now, regarding surgery specifically, though, in that particular trial, they also went on to show that about 59% of the patients ended up having a surgical procedure to help with management of the primary, and that included having catheters or suprapubic tubes, TURP, cystoprostatectomy, even pelvic exoneration. So that includes basically a little bit more than half of patients overall. Also, just to kind of note, and this is probably more important from the medical oncology side of things, once patients develop a complication and they get some sort of treatment for that, it doesn't always mean that they're going to be returning back to their previous baseline. Sometimes they don't recover fully, their performance status really suffers. It may get to the point where they have basically a performance status of 3 or 4. They have trouble taking care of themselves, getting out of bed, and they certainly may not be candidates for certain types of treatment, including like chemotherapy, for example. So just to kind of keep that in mind, it's not just about the primary itself, it's also about the long-term picture. Of course, all of that comes with a financial cost as well. So a lot of different things to consider. How prevalent is this problem? Well, it's already, as described above, occurring in about half of patients or more, but it's probably going to continue to worsen. Dr. Brooks already threw up some slides about the prevalence and incidence of metastatic prostate cancer rising due to a lot of different factors, including better imaging techniques, less PSA screening, and overall, definitely our studies have shown that the incidence is truly rising. Okay. So beyond palliation, is there a role for local therapy? And this is hypothesized from a lot of different reasons. One theory is that the primary tumor itself can secrete different factors, including interleukins, growth factors, endocrine factors that can actually promote proliferation and growth at metastatic sites. Our own Dr. Cadman actually, I think, conducted a study many years ago looking at rats who were carrying tumors with certain prostate cancer cell lines, or from certain prostate cancer cell lines, who were then treated with surgery and chemotherapy, and versus some with just surgery alone. Those who were treated with the addition of the chemotherapy actually had a survival benefit. Also, there are a number of studies that show that within the prostate primary itself, there remains some clinically relevant disease despite chemotherapy or systemic therapy. For example, one study showed that after 1 year of chemohormonal therapy, patients who went on to have a prostatectomy, the prostate tissue was actually analyzed, and within the cells, they did a lot of other molecular studies that showed that some of the pathways that were upregulated contributed towards progression and metastases. Also, there are basically about, I think, 2 studies that looked at a small number of cases of patients who had whole genome sequencing or deep sequencing, and it was pretty interesting that they were able to show that our usual idea of how prostate cancer progresses is that the primary seeds metastatic sites, but there's actually, in fact, a lot of crosstalk between the prostate primary and the metastatic sites. The metastatic sites can actually seed back to the primary as well and crosstalk to each other as well. So for people who don't have maybe potentially just a few metastatic sites or oligometastatic sites, it may play an important role. Of course, in other cancers, there's the Scopal effect that's been relatively well described, but in a small series. I don't believe I saw a case yet where that was evident in metastatic prostate cancer, but that doesn't necessarily mean it's not true. But overall, if you treat the primary, you could potentially also have distant effects on metastases. And also there is a series of retrospective studies, which I'm going to go into here, that also show and suggest that there might be a survival benefit related to local therapy. So here's a large table, and it certainly doesn't include all the different studies, but I try to include basically the ones that have the highest number of study patients enrolled. And as you can see here, most of them are actually from large cancer databases. The numbers of patients on these trials are numbering into the thousands. The patient population here was quite variable. Some of them included M1A, which is prostate cancer patients who have metastases only to the lymph nodes, B, which is bone, and C, meaning visceral sites. So a wide variety there. In terms of local therapy, there are different options here from all the different trials, including radical prostatectomy, radiation therapy. Some didn't really specify, as long as it was some sort of local therapy as well. Primary outcome was mostly either mortality or survival. And as you can see, I'm not going to go through every single result, but if you look down on the hazard ratios, most of them did suggest a benefit in their primary endpoint. I did want to highlight something that was kind of interesting here, which is that in the third row, they did look at actually patients who had M1A disease versus M1B and M1C. And it was kind of interesting, only those essentially who had potentially oligometastatic disease to the lymph nodes, in this particular study, it did look like local therapy conferred a survival benefit. However, those with visceral disease or visceral metastases, it did not have a potential benefit there. And for those with bone disease, actually, it was a little bit mixed. They did stratify that a little bit further, looking at the baseline PSA value. And those who had a PSA less than 60 did seem to have a benefit. Okay, so moving on to the prospective studies, I'm going to first discuss horad out of a total of 2 trials. Horad was a study where patients who had metastatic castration-sensitive prostate cancer were treated with ADT plus or minus prostate radiation. Key eligibility criteria for the patients on this study were, of course, that they had to have de novo untreated metastatic castration-sensitive prostate cancer. They could have had any number of bone metastases, and the Gleason and T staging are there as documented. It was interesting, on this study, patients were only required to have a bone scan, and they did not have necessarily have to have a CT scan or anything further than that. In terms of treatment, radiation was done to the prostate only. And there are sort of two sort of schemes for radiation that were done. One included basically EBRT at 70 gray over about 7 weeks. And then also they did about 57 gray over about a 6-week period. The primary endpoint on this study was overall survival, and the secondary was time to PSA progression. And looking at the chart on the right-hand side, I did want to just mention, they didn't actually stratify in this study the number of bone metastases. So you see sort of an unbalanced group between the 2 arms, between patients who had less than 5 lesions, 5 to 15 lesions, and greater than 5 lesions. So. And these are the 2 primary endpoints. Overall survival and time to PSA progression. As you can see here, survival didn't really change or differ between the 2 arms. However, the time to PSA progression certainly favored those who had the addition of radiation therapy. If you look at the subgroup analysis here, the patients who had less than 5 bone metastases seem to have more of a benefit than the other higher, than the patients with higher numbers of bone metastases. So in conclusion here, no difference in overall survival, but there was certainly a trend towards benefit in those with less than 5 bone mets. Okay, so moving on to the second study here. This is a stampede trial. This was a multi-arm, multi-stage trial that I think we're all familiar with. A number of years ago, they did report the patients who, basically the impact of radiation in a few of their patient population arms. The key eligibility here was that, again, patients had to have newly diagnosed metastatic castration-sensitive prostate cancer. On this study, they actually used the charted definition of low and high disease burden, and that would be greater than or equal to 4 bone metastases with one bone lesion outside of either the vertebrae or the pelvis, or if they had visceral metastases. Staging here on this study was done by CT scan and/or MRI and bone scan. And in terms of treatment, they did a 1-to-1 randomization between standard of care, and of course there were different definitions there, but basically standard of care plus or minus radiation. Docetaxel, chemohormonal therapy, was approved in the middle of this trial, so it was allowed after that. And in terms of radiation, they actually used a lesser amount of dose, including 2 schedules, either 36 gray or 55 gray. The primary endpoint was overall survival and failure-free survival, and secondary endpoints were progression-free survival and metastatic progression-free survival. So, okay, and looking again at the primary endpoints here, no difference in overall survival. Failure-free survival did seem to favor a benefit significantly with those getting radiation. And again, looking at the subgroup analysis here, patients who had low disease burden definitely had more of a benefit than those with high disease burden. Looking at the survival curves by tumor burden, on the top there, basically you have overall survival going across. On the bottom row, you have failure-free survival. And then on the left-hand side, you have low metastatic disease and high metastatic disease on the right. You can definitely see that the low metastatic disease burden patients had an improvement in overall survival and failure-free survival. So there are a number of ongoing studies here. I've listed a few of them. 2 that are sort of particularly interesting to me are the Peace 1 study. I know that recently that's been discussed, but not really regarding the impact of radiation. So those results are awaiting presentation. Also, the SWOG 1802 trial, which is a trial that we actually have open as well at our facilities. This is a phase 3 trial looking at standard systemic therapy plus or minus local therapy, and that could either be surgery or radiation. The primary endpoint of that study is overall survival. So I think these studies have highlighted a couple of future questions that we should look at specifically when the newer studies come out, and these are as below. So first of all, which patients will or will not actually benefit from the additional local therapy in a metastatic setting? And a couple of risk factors there to look at would be whether or not they have a certain amount of disease burden, whether or not they have good life expectancy. Should we be looking at M1A, M1B, maybe some select M1Bs as definitely is of interest in a lot of different clinical trials. Also, in terms of staging and stratification, which staging scans are going to be implemented and useful. You know, as you know that we saw earlier, bone scan was using horad, and stampede used conventional imaging, but we haven't really seen yet one that's using some of the new molecular imaging techniques. Also, just to kind of throw that out there, I wouldn't be surprised if one of the studies does have some sort of correlative endpoint, looking at some sort of molecular genomic marker, and that could be potentially helpful as well. Also, in terms of concurrent treatment, does concurrent treatment really make a difference, and what exact concurrent treatment will make a difference? In terms, like for example, in terms of surgery, should we do a smaller procedure? Should we do a prostatectomy up front? Should lymph nodes even be done as part of that? In terms of radiation, which dose of radiation actually matters? Should we go and treat with a radiation dose that's kind of in the palliative range of more about 30 to 50 gray, or should we be using 70, 78 gray, 81 gray? So in summary, for those people who are getting local therapy, not necessarily for palliation's sake, I definitely believe that this is a good opportunity for those kind of patients to be included on a clinical trial. There certainly are a whole bunch of those trials open. Thank you very much.